Hi, everybody. We're going to go ahead and get started. We're trying to move so-called Yale time back as close to 3 o'clock as possible, rather than 3:05, which has become an increased tradition. So it's really great pleasure to, I don't want to be standing in front of you there, David, to introduce Dr. David Awe from University of Washington and Puget Sound VA Medical Center as our Grand Round speaker today. Dr. Awe, just by way of introduction, did his undergraduate degree at University of Chicago. He received his MD degree also from University of Chicago Pritzker School of Medicine, and his MS degree from the University of Washington School of Public Health in the Division of Epidemiology. He did his internship and residency at the Case Western Reserve University and University Hospitals of Cleveland, and subsequently did his pulmonary and critical care fellowship at University of Washington. He joined the faculty in the Division of Pulmonary and Critical Care at University of Washington in 2001 and is currently professor of medicine there, and is based primarily at the Puget Sound Veterans Administration Hospital. David has received numerous honors and awards over the years for his teaching as well as from his research, both from his home institutions as well as national organizations and societies, including the Veterans Administration, the American Lung Association, and the American Thoracic Society. Some recent examples, certainly not an exclusive list, include a Lifetime Achievement Award from the American Thoracic Society from the Behavioral Science Assembly in 2012, an ATS Research Innovation and Translation Achievement Award in 2021, and most recently in 2023 received the Samuel J. Sills Distinguished Scholar Award from the Trudeau Society, which is indeed a distinguished honor. He has mentored innumerable trainees who've gone on to highly successful careers in academic medicine, including and amongst which are Dr. Seppo Rinne, who is one of our former internal medicine residents and faculty members, who's up at BU now. He works also very closely with Dr. Christina Crothers, who's well known, close faculty member, former faculty member here as well, close colleague of ours. He's held several leadership positions within the ATS over the course of his career, has been a participant in several NIH, NHLBI workshops, review panels, and data safety monitoring boards. He's currently the acting executive director for the Center for Care and Payment Innovation in the Office of Healthcare Innovation and Learning at Veterans Health Administration. He holds extensive research grant funding from the NIH and the Department of Veterans Affairs, as well as the ALA. And his work is centered on care, quality, safety, and evidence-based practice for people with COPD. He has authored more than nearly 200 peer-reviewed manuscripts, as well as chapters, reviews, guidelines, workshop reports, et cetera, in such distinguished journals as JAMA, the Blue Journal, Annals of ATS, International Journal of Environmental Research and Public Health, PLOS One, CHEST, Lancet Respiratory Medicine, and many others. He's really one of the giants in the field of COPD internationally, and a wonderful colleague to many of us. And it's really a great pleasure to welcome you today, David. And he'll deliver his talk entitled "An Option But Not the Priority, Closing the COPD Quality Gap." David, welcome.
Thank you. I'm humbled to be here. As I was saying earlier, this is actually my first time in New Haven at Yale campus, so it's still really a delight to be here. Christina Crothers did ask me to say hello to everyone on her behalf. So I just wanted to make sure I did that. Otherwise, she's really my boss at the VA. So like I would get in trouble for that otherwise. Do I use this? Okay, great. So today I'll talk a little bit about of a journey and a little bit of an opportunity I think that we have as specialists in the world of pulmonary critical care medicine, really focusing on an example of COPD, but I think there are many places where we could actually exert influence as well. And I think you'll see why I come up with the title of "An Option But Not the Priority," which is a common theme that I've heard, not only from the issues around COPD, but other issues around relationships and with our academic affiliate and other things. So why don't we go ahead and get started? So I can do this. Great. this is my conflict of interest and disclosures. So as with the Department of Veterans Affairs, although we may have this disclosure, I have other disclosures, which are that these views really represent mine and not the Department of Veterans Affairs. So I just want to be clear. Okay. So this is where my journey started really this is my first publication in 2000 in the Blue Journal. And this was a delightful paper that where I worked with this internationally known cardiovascular disease epidemiologist by the name of Bruce Bisady, and my mentor, Randy Curtis, who I'm eternally indebted to. But this was a fascinating paper in that we had, I've been given this opportunity to look at the relationship between short-acting beta agonists and the risk of myocardial infarction in this well-defined cohort, this data set. And what we found and why it was published in the Blue Journal, I think it was because there was like a 7-fold increased risk of incident MI associated with new use of beta agonists. And it was kind of an intriguing association. But it left me with the question of like, what was the clinical implication of the work itself, right? There was biologic plausibility in that, new users of beta agonists, when first people use it, you can get a little bit of reflex tachycardia associated with it, and that might increase your risk of MI. There's also associations between like viral respiratory illnesses leading to, wheezing and the like, and then MDI use subsequent to that. There's also non-biologic plausibility, which is that, or possibilities that include things like they're developing angina symptoms and someone misdiagnosed their angina as airflow obstruction, and they gave them a beta agonist instead of, a beta blocker or some other anti-anginal. So the issue around, and it made me think a lot around causal inference, which is a global theme in my life right now, which is thinking about how you actually know what we study is true, right? And I spent a lot of time in my career focusing on mechanisms to address confounding by indication, using things like propensity models. We see this a lot in the sleep literature right now. Instrumental variables, adjustment, regression. And the reality is that none of these opportunities to improve causal inference actually lead us to a cause and effect relationship, because the issues around confounding are so strong that none of these approaches actually address it adequately. And that left me a little bit dissatisfied in the fact that I couldn't actually think about, what associated action was associated, what the subsequent action should be after describing this association. We weren't going to do a randomized clinical trial on it. There was no way to address it really in that way. But as we were going through these thousands of records over time, what became apparent was really, you could actually get a sense of what care was being delivered and what that quality of care was going to be. And that's actually a pivot for me over time, is this thinking about the causal inference and what you could do about causal inference to really, no one could quibble with us really about measuring what the quality of care was that we were observing within the clinical records. So I think especially in this kind of pseudo-COVID, we're in mid-COVID, where people have a tendency of not coming in to work, they're working from home, they're working in isolation along the lines. I think this is a particularly important part of the conversation, which is that number of small collisions that occur in interactions with people actually can help us understand like the direction we should be going. And so a pulmonologist, so this is the Klickitat River in Washington State, which is along the southern border between Oregon and Washington. It's a great steelhead salmon river. So if anyone wants to come and fish, let me know. I'm happy to take them there. But I was fishing with a friend of mine who happened to be a primary care provider. So I am the pulmonologist in this story. And we were talking a little bit about the empiric use of beta agonists for shortness of breath. And my primary colleague said, well, it's not a problem. Patients come to me and I have a little bit of dyspnea on exertion. I give them an inhaler and they get better. What's the big deal, right? And I'm like, but think about this, right? So you have a person have dyspnea on exertion, you give them an inhaler. What do they do with that inhaler? They're walking, they get short of breath, they pull it out of their pocket, and they kind of wait for a second, then they take a couple of deep breaths, at least 2 deep breaths with actuations, and and then they feel better, right? And so it's like impossible to disentangle. Are they feeling better because they stopped and they have actually recovered, or are they getting better because of the medication itself, right? It's impossible to disentangle. And then and I said, don't you want to know that this medication is actually having an effect? And like, no, it's fine. And I was like, and this discussion ensued, and this is a good friend of mine. And so like, and we've had many heated conversations. And so this was like a discussion, but it was really a little bit of like a friend argument kind of stuff. And then I left dissatisfied with that conversation because he was so embedded, he's so entrenched in the idea that like, no, you don't need spirometry at all. And so I was like, fine, whatever, let's go on and fish. So that brings up the idea of like, when we have evidence, like how do we use that evidence or how we adapt to that evidence over time, right? So when we think about changing clinician behavior, oftentimes there's this paradigm, right? We're exposed to new information, and then there's this critical assessment of perceived new evidence, and there's an intention to perform this new intervention, and then you scale up this effective intervention. That's in practice, right? So if we're thinking about spirometry, it may be there's a need for evidence for the use of spirometry. You measure the proportion of people who are getting spirometry in the field, and then you might think about how do we measure clinicians' intent to change that practice, which I gave just a hint of, and then you can perform, new measurement looking at whether or not spirometry has been adopted and the like. And so this is kind of the classic way we've been approaching problems over time. And I would say that this is really when you see something published in a journal or the like around new evidence, this is the expectation that they have of you to adopt this new practice. I'll say that this is not a new problem, right? So failure to adopt is one that goes way back, and probably among the more famous ones that are used in the medical literature is the one around scurvy. And although I'm mentioning scurvy and I'm measuring some evidence, I'm actually not 100% sure it's true, because I went and did a bunch of reading, and I'm not exactly sure it's, it's like, it's a little bit fuzzy out there, when you're reading these like old texts. Some of them are like transcribed, some of them are not transcribed. It's a mess. So this is the best I got to it. So give me a little bit of room here. But classically, we ascribe the first clinical trial to Lind, right, in 1747 above the Salisbury. And this was functionally a cluster randomized trial, right, where he provided some ships with citrus products, other ships with not citrus products, and every single ship that was provided citrus product had no mortality from scurvy. And scurvy was a large cause of death during that time. And every ship that did not get citrus products had a good amount of scurvy and scurvy deaths. But it took 40 more years from that description for the British fleet to adopt the use of citrus products in the among sailors, right? And so it's evidence of slow to act on really definitive information, right? Except the story is not even really probably about 40 years, right? As I was reading through, I found this reference to Sir James Lancaster from 1601, so a good 200 years earlier. On the Red Dragon had similar descriptions and the like. And in between them, there were off and on reports around the potential benefit of citrus products in the prevention of scurvy. In that literature, there was important hints of implementation gaps that we see today, right? Some people say it was observational, right? So, as I was, lamenting earlier around causal implications, like they recognized that back then. There was really a lack of consensus, and even Lind himself questioned his own findings, like could it be true, could it not be true, and the like. But there was, in the treatise, there were 57 reports of different, the use of citrus products and the like. There were skeptical experts, which, maybe Naftali was a skeptical expert in the field. And there are alternate theories of scurvy, right? And so this is where you have two competing groups that are kind of vying for fame around, preventing scurvy death and like, so they're kind of at odds with each other. This one is really important, extremely painful to read, right? And so this is like, if you're reading something and you can't get through it, you're not going to get through it. And then this is the last one, which is it is not being acted on by individuals who could lever delivery, right? So that although Lind knew about this, the admirals of the British fleet didn't know about it, right? And so there was no translation between where the information was generated, who held that information and to the people who could actually act on that information. And as we think about that now, that is a concept around discovery to impact, right? And so we start to think through what are all the kind of components of that. And this is the kind of classic model where we have observations, we do efficacy studies followed by effectiveness studies. It enters this kind of black box, and we assume that it's going to have wide scale uptake that leads to impact that we can measure over time. But here the question is, what is in this black box, right? And these are all the things that could help or actually, delay uptake within an impact, right? And these are things like, if you're a Donabedian, like Donabedian structure process outcome kind of person, then there's some of that here, right? There's structures and processes that would support it. There are clinicians, there's clinical leadership, and there's clinical knowledge. There are competing priorities, which you'll see in the COPD story as a major issue. There are patient factors, there's clinical inertia. There are other really important things in this modern age of ours called the C-suite, right? Because they actually control important levers around resources and like. There's populations, cost, and clinical efficacy. And these are all areas that really can impact and sit in this black box that we don't traditionally talk about in terms of taking discovery into effective delivery. So let's pivot back a little bit. This was there are several sentinel papers in this talk, and this one is from Peter Lindenauer in Annals in 2006. And Peter, who's actually not that far from you, right? He's at Bay State, looked at a large cohort of about 70,000 patients that crossed about 360 US hospitals. And who had about a 17% readmission rate. And he was really asking questions around how good of care are we providing for patients with COPD? And he looked at all the recommended practices, and looked like we did that pretty well overall, except for the use of NIPPV, and that was among patients who had respiratory failure. But then he also asked the questions, how many therapies are we giving that actually are not recommended as part of this hospitalizations, and measured those across. And then he created these scores, these composite scores, where patients received all the recommended therapies, that portion of patients that received at least one non-recommended therapy, and then what he just described as ideal care, which is people receiving all the recommended therapies and none of the none of the non-recommended therapies. And what you see is that 66% of patients, and this is hospitalizations across the US, 66% received all the recommended therapies. About 45% received one or more therapy that was not recommended, leading to a concept of ideal care, which was only about 33%. Whoops. If this would advance, so we'll say 33. There it goes. 33% ideal care. And so this was an important paper in the sense that, this is really one of the first times that we were really kind of objectively trying to look at the delivery of care, right? And so, people have subsequently replicated this in different settings, but this kind of concept has continued to come out. This is data really from Laura Feimster's group, and this is a paper by Tom Keller. And looking at the quality of care, outpatient care, in an academic health setting. And I'll tell you, this is the University of Washington, right? So the university site is UW Medical Center, and our associated primary care clinics in the county is Harborview Medical Center. So, and so you can see, we're a pretty good hospital system, but we don't actually do all that well. So for example, spirometry, symptoms assessment, and we're very liberal with how they define symptom assessment, oxygen use, pulmonary rehab was really bad and consistent with the country. The use of LAMAs and LAVAs, prescriptions and the like were all, really around the 50% margin or so. I will say, we seem to do better on things like smoking cessation and smoking status assessment, but I would also argue that these are not COPD specific measures by any means, right? Because these are done in primary care settings, and these are JACO measures, and these are also HEDIS measures and the like. So they're not COPD specific. But if you go back and focus on spirometry for a second, you can see that really about 60%, 50 to 60% of patients at the University of Washington Health System were getting spirometry in the primary care settings. So why is that? So thinking back to NELUP, does everyone know what NELUP is? This it was published in 1997, right? This paper, but it started actually well before that. That's the National Health Lung Education Program, stood up by Tom Petty, who's the first author here, and Gail Wyman. And really, they had this notion, they recognized this problem way back in the 80s, and really started an initiative that really tried to promote the use of spirometry in primary care clinics. And I think they did everything right. And they identify that the bulk of patients with COPD are not actually seen by us, right? They're seen in primary care clinics. They had went through the process and identified all the barriers to spirometry use. And then they went and provided training and provided spirometers, primary care settings. They were at the elbow, which is like a grade 1 recommendation to do when implementing something new. They provided the needed equipment. They showed people how to do spirometry. They trained them on the use of spirometers. They taught them how to interpret the spirometry results. And most importantly, they taught them how to bill for it, right? So is really the whole kind of, the whole suite of activities. And the challenge here, of course, is I showed you data from the University of Washington, and it's actually not that different if you look at across the way, which is the use of spirometry has been poor across most health systems and approaches, right? So these are back in 2006, 2005, the use of spirometry for COPD became a HEDIS measure, right? So it's a quality of care measure that can be indexed to hospital programs. And it didn't really matter if you're a commercial HMO, Medicare HMO, commercial PPO, Medicare PPO, Medicaid HMO, or the like. The use of spirometry had a small uptake, for a couple of years, and then it's been flat ever since, and it has not changed, right? And so, as someone who cares about COPD and cares about the first step, which is to have an accurate diagnosis, it really left me feeling like, what are we missing, right? And so, and I do consider this like a one-sided romance. Like, I feel like I'm this person right here above in this Gary Larson. Like, I wonder if she knows I exist. Should I call her? Maybe she doesn't, even though I know I exist. Well, maybe, exist, dang, and then in the bottom caption, I think I really like vanilla, right? I mean, it's like same planet, different worlds, right? And so I'm here like, I really want you to care about spirometry. And they're like, no, I don't really care about spirometry. And so, but this is really kind of the classic approach. NELUP and what we had done before was really the classic approach, right? We provided knowledge, private education, taught them how to use it, and everything will just be adopted, right? Because we're rational actors and we'll want to do what's best for our patients and the like. But obviously, the data from HEDIS shows you that that's not correct, right? And it was really this paper of Min Ju's from UIC in 2013 that was really a seminal paper for me, because up until 2013, I'd been like, God, we got to get primary care to do this. We got to get primary care to do this. And what Min did, which was so brilliant, is she went and talked to primary care providers, right, around different kind of clinical scenarios and whether or not they would find value in the use of spirometry. And I'll just kind of lay it up front and say they found no value in the use of spirometry, right? So thinking about the patients that they inherit, right? So if they inherit a patient who has a diagnosis of COPD, I mean, how often do we see this, right? There's no spirometry. They feel no desire. They don't think there's any value in getting spirometry to confirm that diagnosis, even though we know that there's at least a 50% probability that they don't have disease. Okay. They also feel like they don't need it in newly diagnosed COPD, right? This is like my friend at the stream side, like, no, if they're coughing, they have symptoms, I give them a bronchodilator. I don't really care what the ratio shows. It could be 79, it could be 74, whatever. It doesn't matter. They have COPD because they feel better. This is also an important concept that, like, I'm a pulmonologist. I'm interested in COPD. Why aren't you interested in COPD, right? And they're like, it's not that important to me. And they actually were very explicit. That was low prioritization. They say, we see a lot of obesity, diabetes, hypertension, hyperlipidemia, and they treat those conditions well before they think about, the quality of care or anything dealing with COPD. And then also there's this hassle factor, right? That, like, because oftentimes, even though NELIP was around and the dissemination of spirometry is not universal by any means. And so there was concern that it would be a hassle to patients. Like, why would I send my patient to do this test that may be a hassle when I actually don't see any value in it in myself, right? So it's not a good use of their time. It's not a good use of my time. But this has, this has implications and like. And so we were interested in what are the factors then that lead to misclassification of disease, right? Because if you don't have COPD, then you have shortness of breath, you have something else, right? And so this is work from Bridget Collins back in 2014, where we had this large set of patients who had spirometry. And we just asked the question, like, what are the factors that are associated with misdiagnosis functionally, right? And you can see, the correct diagnosis, and you can see everything that has a factor that's related to dyspnea. So deconditioning, obesity, heart failure, as reflected by weight and the like, are all related with a greater probability of having the correct, having the incorrect diagnosis in this case, right? And they're all statistically significant, and but it explains at least some of the etiologies of these misdiagnoses. The next question is, we know that, so of these, roughly 2,700 patients who didn't have airflow obstructions, then you can ask the question, are there factors that lead to appropriate, next steps, which would be, if you don't have airflow obstruction, you would want to de-escalate therapies, not escalate therapies, right? And so, and in this case, we just looked at weight. And you can see that the higher your BMI went, the more likely you were to inappropriately escalate therapy. And that the higher your weight went, the less likely you were to appropriately de-escalate therapy overall. So really, this jives with the conversation at the stream side, right? It doesn't really matter what the findings show. If you have a symptom, they're going to try to treat that symptom. And if that symptom seems like it's, at least partially ameliorated, they're not going to think about it anymore, and they're just going to move on, right? And my friend's conversation was like, what does it matter, right? And I would suggest that it has a lot of importance, right? Because there's a lot of consequences for poor quality care in terms of both overtreatment and overdiagnosis. And for patients, they may be treated for COPD without actually having it. And they're using treatments that will not work for obesity or heart failure or, or depression and the like. And that they may actually increase harms through the use of inhaled corticosteroids. Matt Griffith published a paper showing that even among people who don't have airflow obstruction, when you start an inhaled corticosteroid, you increase the risk of pneumonia. And so for both patients and health systems, there's opportunity costs. And this is a cost that people rarely think about in life and especially in healthcare, which is that when you're not focusing on the primary etiology of the disorder, you're missing an opportunity to treat that disorder, right? So people out there who have diabetes or obesity, their deconditioning and the like is being attributed to a condition for which they do not have. It also leads to unnecessary medical expenditures, who decrease our revenue, potentially decrease their revenue for COPD visits, but it would also actually save them money from medications, and inhalers are actually not cheap anymore. And so we went back, and Laura Spiess in 2019 went back and looked at, had these care gaps closed since Peter's publication. And I'll just save you a story by saying it hasn't closed at all, and it's remained exactly the same. And as you look at the timeline, this quality of care over time, it's really flat and has not changed at all. So. And this is not just in the inpatient setting, in the outpatient setting. This is work from the Spiromics group that looked at, whether or not patients who were in the cohort actually aligned to GOLD recommendations. And really only of the 1,700 patients or so, about 52% of patients aligned with GOLD recommendations. In non-aligned regimens, 46% had underuse, and 54% had overuse, primarily through the use of inhaled corticosteroids. They went back then and looked at 431 patients who were followed over time, and there was no change in in these findings over time. So even though the evidence was out there, there was no increase in uptake. There's no, of these recommendations, things remained exactly the same, which is a little bit disheartening because over that time we've been generating knowledge and disseminating knowledge and the like. So in that context, it really changed the paradigm of how we've been thinking about this problem. And it highlights how do we actually then affect change, right? If the primary patient population lives in an area or is seen in an area that we don't practice in, there is no opportunity there's no opportunity for us to, diffuse our knowledge, our specialized knowledge to this population at all. So the question is, how do you affect change at the patient and provider level? So we need to think a little bit about the traditional specialty care medicine approach. And I'll tell you that this is just a map of something called a VISN within the VA, which represents a geographic representation of the area. And the areas in gold represent population densities that have no exposure or are removed distance-wise from lung cancer screening programs, right? And blue areas are where there's a CT scan available to do low-dose screening. But it highlights that that there is geographic dispersion within our populations, and that there's concentrations of where there are CT scans are typically where specialists live, and where there are gold areas without, blue is where there are no specialists around. So it highlights this geographic disparities that we have in medicine itself. And the other problem with traditional specialty medicine is that, and I'm not a sports person, so these are the only times I ever really use sports slides, is that it really does, like, we're the catcher here, right? We are specialists. We're waiting for that patient to be pitched to us as in the form of a referral, and that we oftentimes catch that patient and take care of that patient. Except this is actually the Seahawks versus the Pats, where I think there's an interception like at the end zone or something like that. And so like in Seattle, this is not a popular picture. We lost that Super Bowl. And so but it also represents the idea that even when you throw the ball, sometimes it's not perfect. So in like the VA, for example, 50% of our referrals to the community are never filled. So like we send, 50% of referrals go out to a specialist, and that is just dangling out there in the ether, and no care is being done. So even though there's a system to set up for, to receive people, it's really not perfect. There are other problems with the referral process, right? The first one is that it's not population-based, in that there are patients out there, and it's really dependent on the quality of your primary care provider or the provider who's making the referral to actually recognize that there's a problem to make that referral, right? And so, and it's reactive by nature, meaning that, we're just sitting here kind of waiting. We're just like a binding site that's looking for, something to bind us to stimulate our activities. As I mentioned earlier, patients don't live close to specialists. And oftentimes, when we send people out to the community, I'll send them out for an echo and they'll come back with a left heart cath. And so I'll still have no idea what the right heart, what the right atrial pressure is, even though that was a specific question I asked for. And so it's not really what the patients need, is not what I need. And so it's not perfect, right? So then we have to start thinking about, okay, so then how do we start thinking about affecting change in a way that works for the system? And this is where I start talking a little bit about behavior and economics and the combination of behavioral economics. So that is Dale Kahneman and Tversky, who wrote this book called Thinking Fast and Slow, based on a plethora. They're psychologists, and so they won the Nobel Prize. I don't remember what year. This is Rich Thaler and Cass Dunstein from the University of Chicago, who wrote the book Nudge, that served the basis of a lot of kind of behavioral economics in what we do. And so their work, I think, has been pretty instrumental in thinking about how we can take things on at a population level. So first, the behavioral economics of it. So medicine is really the paradigm of behavioral economics, fostering poor quality care. Like type 1 thinking. So this is Kahneman University. They talk about type 1 thinking, which is fast and reactionary. And this is where I think we spend most of our lives. Type 2 is slow and reflexive. And most of healthcare is about being fast and reactionary. So especially if you're in a health system that's owned by an equity group, right? They don't care about you being, reflective and, engaging time with patients. What they care about is revenue and revenue generation. And it's been well shown that, groups that are owned by investment groups actually overuse resources in ways that performance. And so most healthcare systems are about seeing a lot of people. There are a lot of problems to address, and there's oftentimes not enough resources to support them. And it relies heavily on type 1 thinking. The problem, of course, is that if you're spending your life in type 2 thinking, you're exhausted at the end of the day, because everything can't be considering this and the like. And so the tendency in medicine is really to rely on our type 1 thinking. We recognize a problem, we act on that problem, and we move on. We don't think about it again. So the question is, how could we start to restructure the approach to deliver services, right? And there are all these other issues, right? So inertia by definition, right? Is change is hard, right? And what we really want to think that we're rational actors, right? This is what Milton Friedman would say, right? That it's in our best interest to take care of patients in the best way, because it serves the patient's good and it serves our good. That's how a rational actor would think. But empirically, we don't do things that are always logical to do, right? Our brains, for example, favor preventing loss over gain. That's not really rational. As I mentioned earlier, our brains are designed to be lazy, right? We want to conserve energy and the like. And in certain contexts, we have these best intentions. Like, I know I eat too much, right? And 10 o'clock at night when I'm doing some work and I just want to munch on something, I'm going to munch on something, right? Even though I know in my heart of hearts that's not the right thing to do, right? And so the best intentions are quickly forgotten over time. And then I said, deep reflective behavior is hard because it takes a lot of mental energy and the like. And so what Cass Sunstein and Rich Thaler developed was this concept called libertarian paternalism, right? And they did this in the context of savings plans. And so you're what am I blanking on here? These are our IRAs and the like, where we can have match contributions and the like. And what they did at the University of Chicago is they said, well, when you're coming into these programs, the default used to be that people would have to actually default into a particular types of savings plan, right? What they did is they said, what we're going to do? We're going to have the default be, we're going to contribute X% of your salaries into your savings plan. And then we're going to monitor growth of your retirement accounts over time. And what they showed was that the default led to significantly greater money at the time of retirement, which is a huge deal when you think about the average retirement for the United States. And so the idea there is that you want to make what we think is the right choice, which is in this case, long-term savings, the right thing to do. And you want to make that the default choice. And you just want to make it just a little bit harder for people to get out of that default choice, but still leave it up to them so that they have the option, right, to come out of it. So that's why the idea of you're doing the thing that is paternalistic, thing that we would encourage, but there's also a libertarian side of us that says, you can't tell me what to do, right? And so, but you give them the option not to do that. So how can specialists then improve care across the health system? So so parts of the issues are, and there are a lot of kind of components to healthcare delivery, right? There's the patient-centeredness, the patient component of it. So you're focusing on outcomes, for example, that patients care about, being out of the hospital, quality of life. They want convenience. It's pretty clear that all patients want convenience. The more I use healthcare, the more convenient I want it to be. And that it's pretty clear, if you put a barrier between Yale health system, you put a facility of much lesser quality between you between the patient and Yale, they'll go to that lower quality health system more than they'll come to Yale, just because of the convenience factor. It's been well documented. So, and then you also need if our patient populations are in primary care settings, then you actually want to be able to support primary care. This is not about us, it's about helping them, right? We also want to be able to use population health based approaches where we prioritize issues which are important to us and to the benefit of patients overall. We want to be able to identify patients at a systematic level. We also want to be able to address gaps where services don't exist, like the geography problems that we were talking about earlier. And then we have to address issues that may be relevant to the health system in terms of efficiency, cost, quality of care. Because anything that you design as a health system intervention, if it's too expensive or it's too onerous for the health system to adopt, they're not going to adopt it. It's just a simple thing. Like there's no they'll do it because it's the right thing to do. It has to actually make sense for them to do it. This is something that's different than most quality improvement initiatives, which is that I think in what I would encourage that when we start to do these kind of activities is to use experimental designs, because what we really care about is the inferences, and the inferences are what drive good decision making. And if we don't have good quality data, you're not going to have good quality decision making. So I'm just going to give you an example of something we did that was called InCase. I don't remember what the acronym stands for, but something around exacerbations. But we tried to incorporate these objectives into this clinical trial, and it was a pragmatic design to try to utilize a population-based approach to identify highly vulnerable, high-risk patients. In this case, these are patients who were recently discharged with a COPD exacerbation. The whole idea of the trial was to support primary care providers treating these patients. We collaborated across multiple groups. So we used specialty care medicine, primary care, and pharmacy. And we took the reactive component away because at the time, about 19% to 20% of patients who had been discharged with a COPD exacerbation were coming to pulmonary. We took that away and just said, we're going to see everyone who was discharged from the hospital. So we were being proactive. This was a health system level intervention. So patients actually didn't know they were involved in this intervention at all, at least during the time of the intervention itself. And only the intervention recommendations were going to providers. We wanted to deliver the care within existing context of care. When we suggested adding new clinic visits, primary care were like, you're crazy, right? We're already inundated. We can't do anything more. You can't add anything more. So you had to do it within the context of the existing environment. We used the VA information system, which at the time was pretty unique, but I think now most EHRs can do this. And then we also wanted to kind of respect and minimize the workload and preserve the autonomy of the primary care environment, which we call PACT, the VA. And so we were monitoring readmissions or death within 6 months as our primary outcome, and as well as quality of life as measured by the CCQ. And this is actually how the intervention was just designed to go. And so we would use EHR to identify patients who were discharged from hospital. We would do a chart abstraction within a week of that discharge. We would meet as a team to kind of review those recommendations. And the early part of these were like team meetings where there was primary care, pharmacy, and specialists. By the end of the intervention trial, I can tell you it was just one person doing it on their own. And the main benefit, I think, for us is that as pulmonologists, as specialists, we have a language and we have an approach to making these recommendations that drive primary care crazy, right? And so a lot of what we were doing was getting the language right, so that we wouldn't seem antagonistic. We would also do things like we would see like recommendations for smoking cessation in the record, right? That they had been trying, but then they would say things like, "Don't tell us to do smoking cessation recommendations because like we've tried it, for the last 7 years, and you're just telling me to do something I'm already trying to do." That is like patronizing at its most basic level. And so that was really useful to really understand their perspective around what they want to see. We had 2 arms. This was a cluster randomized trial of primary care teams. So one set of teams got a note The other team got nothing. But in addition to the note or the e-consult that we provided, we used behavioral economics. We did choice architecture so that anything that we saw on the record that we thought was a strong recommendation, we filled out the order set for the primary care provider so that they could read our note, they could look at the order set and say, is this what I want to do? And if they wanted to do it, they could just sign the note in the order and they'd be done. If they didn't want to do it, they could just continue the order and it would be done, right? And so we try to make it as easy as possible to adopt the recommendation we were trying to. And then, we sent the note and the recommendations, and then we gave them opportunity to communicate with us. And then at 6 weeks, we did patient surveys where we monitored their quality of life, and then we looked for outcomes 6 months using the EHR. And I'll just give you some structure. So this is what it looked like. Just like this is telling them who we are and what we're doing. And then we try to make it as succinct as possible, right? Because they have a ton of notes to read. Like the average primary care provider, I feel for them. They have hundreds of these view alerts that they have to go through. So I'm trying to make it as easy as possible, right? So we recommend diagnostics in terms of PFTs, spirometry before and after. So remember, we've written all these orders for them, so they don't actually have to remember this. They just know that we're doing these things. We wanted a 6-minute walk test, CT scan, because there was some question about pulmonary fibrosis for this patient. We knew that this person had pretty severe COPD, but not on tiotropium, so we had that recommendation. There was some evidence around, like inhaler use, but also things like pulmonary rehabilitation we had recommended. And this is also important because, like in a system like at VA Puget Sound, we have patients that live across the water, right? So on the peninsula, and we have patients that live as far north as the Canadian border and as far south as Centralia, which is about halfway to Oregon. And so, like, there's no way that a patient is going to drive 2.5 hours a day, 3 times a week to come to our center for pulmonary rehab, right? And so, but we know all the pulmonary rehab facilities in the region, and so we're able to actually make those referrals directly to those. We also know what those PR programs want to have before we send them, so we can actually bundle those things up together and send those. And so I think that's a lot of the work and that we're trying to do to affect delivery, is taking things that we know and delivering it to primary care. And then we cite the evidence base, and this is what the effect was, which is we had a non-statistically significant reduction in readmissions or death at 180 days. But the CCQ score did improve. A negative score is a better score, both clinically meaningfully and statistically for patients at 6 weeks. So we consider that somewhat of a success. These are the KM curves that show the divergence over time. We went back and looked to see what are the adoption rates, right, for patients that we made recommendations for. And universally, you can see in red that the adoption rates are actually relatively high. They're not 100%, and that's actually a good thing in my mind, because that means that primary care providers aren't necessarily just signing orders and then like not thinking about it. There's some reflection. There was some areas where there was a little bit of clinical ambiguity in that we made considerations. So we said, we're not really sure, but you consider this, if this, then this. And you can see that there's a clear step down in the adoption of those between recommendations and step down. And I take this in part to be at least some of the choice architecture, because we didn't actually write these as orders on behalf of primary care because we didn't know they were going to be the right thing to do or felt confident about it. And it didn't really matter what it was doing. I think before these were, the previous slide was diagnostics, but the same thing held for both medications and therapeutics. So in general, even things like pulmonary rehab were, which I think was the lowest adoption, was still done around 70% at the time. PCPs generally like the intervention. I like this quote. It wasn't offered as "you moron, you missed this obvious thing to do." It was much more collegial, right? That was the intent. It was friendly. I love this also quote. It would be nice to say, "Hey guys, these guys are in a study. Just letting you know to pay attention. Things will be coming." the funny thing about this study is that we did tell them that they were coming, right? And that they were part of the study, and these were done in focus groups afterwards. And to me, this was reassuring because it meant that the intervention itself was so innocuous that they didn't even pay attention to it. They just kind of, it's just part of usual care, and that goal was achieved. So again, in terms of affecting change, I wanted to pivot a little bit. So we talked a little bit about the patient and the provider, but then there are all these other kind of multiple layers of health system complexity. And so that pivots a little bit of the conversation around, from the clinician perspective, the idea around implementation, practice, and science, right? And so we talk a lot about implementation science, and people use this term implementation. Sandy and I were talking about this a lot. And I just want to highlight, implementation science is not implementation. Those two things are conflated all the time. Implementation science really seeks to understand. Implementation really seeks to do, right? You're doing something. And it's differentiating science from doing, right? And so these are quotes from Ann Sales from a recent NHLBI report. Implementation is the process of planned human behavior under organizational constraints. Implementation science is the study of planned human behavior change. Implementation practice is the process of behavior change. So the one commonality in all these definitions, though, is straight. And that's the other thing that I kind of want to talk a little bit about, because this is an area of huge barriers for successful translation of efficacy, effectiveness into impact. Okay, I'm going to move this along. This is the Yale School of Medicine organizational structure. I don't know it. I mean, I didn't really read it in detail, but I went and pulled it off the web. It is highly complex. And my guess is that if you wanted to affect change, there are a number of these boxes that are going to have to be involved, right? And the question is, how do you actually do that, right? Because you want to be able to actually leverage organizational leaders to have these impacts, right? And so these organizational leaders, they really have their own priorities. They have external forces, they have internal forces, but they do set the priorities for the organization. Carly and I were talking about this earlier around how she got attention of, on the health system on COPD itself. These organizational leaders actually have tremendous pivot, power to pivot, because they control the financial resources, they control human capital and influence, they control most of the landing points for the health system and provider interventions, right? Because they control staff and the like. And so they actually control a huge amount of, ability to actually change things within the organization that you actually don't, even though we have the best desire to do so. And it's also important to remember that my priorities as a scientist and as someone who wants to affect change is not the same as their priorities. So how do you get to that? I mean, there's a lot of ways you can start thinking about it in terms of ways to design successful programs, really just learning and listening from them overall, really trying to align with them. I think one of the more important things is how do you engage them? How do you get your goals to align with their goals, right? They would love to be able to kind of brag about the accomplishments that they supported you with. When you have success, it's their success. It's one of those kind of things where you start aligning. How can you, they're very useful in kind of working out both foreseen and unforeseen barriers. Can you use them to help them brag around quality improvement? They can also help you around, if you help them with their HEDIS measure, that helps them with contracting negotiations with health insurance plans. You can help them think through reimbursement models. I can see how this model would work in a reimbursement model, but you need to help them. You need to help them help you, right? And that's the overall broad message. We've been trying to do this now in a new, larger clinical trial called EQUIP, where we're trying to randomize 4,000 patients to compare pharmacist delivery of population health to pulmonologists, and just comparing practices that already exist in the VA, such as this program here, which is run by pharmacists. But I think the big objective here is really just to point out that when we're thinking about enterprise level change now across the VA broadly. And so we've brought together organizational stakeholders that we think are really important to that. So, in the organizational leader, Angie D'Antolis is the head of primary care for all of VA. Clay Yarborough is the National Executive Program Director for Pulmonary Medicine. Sean McFarland is one of the key leaders within pharmacy, Department of within Pharmacy Benefits Management in VA. We have a number of patient stakeholders that have actually engagement with the VA, including the CPU Foundation. We have a patient engagement panel. We have external. We've been thinking about how to start thinking about exporting this outside our health system. So we have Ken Kaiser, who is a former Undersecretary of Health. We have thought leaders like Jerry Christian and Peter Lindenauer, who you may know. And then we also have people who are interested in payment models, like Josh Lau, to think about how we start externalizing these kind of interventions. So really, this kind of sums it up by saying, a goal without a plan is just a wish, right? And really, the design of health system intervention really is more than us sitting around a table and thinking through like what are the necessary steps. It doesn't require the engagement of a lot of stakeholders. And the methodology that we need to adopt is actually different than what we used to do, right? Where we would have the evidence and disseminate that evidence and assume that the evidence would be adopted. We know that that practice doesn't work. And so you have to start using things like user-centered design, using qualitative methodologies, systems engineering, really thinking about financial models, particularly now in this day and age, including incentive structures to help you incentivize the right type of care. And it's hugely important to understand the organizational priorities so that you can get their engagement, because otherwise your intervention will just kind of die on the vine at the end of the funding period. So I do think that, and this is the final takeaway, which is that, this model really feels like it works well in integrated health systems, but I think there are more and more systems that it can be. If you think about all the value-based contracting that's going on out there, these kind of models could fit in that. If the goal of healthcare quality, if the goal of healthcare is quality at the population health, US healthcare as it currently exists is a mess, right? And we contribute to that mess. And so, like, in as much as I could ask you to engage and think about these problems and think about how we solve these problems, we need a community that actually works together to solve these kind of problems. And I think as specialists, we have a unique opportunity to bring value to the health system in ways that it's not really thought about using us in the past. And as I said, I think we can engage at population levels, which we have not traditionally done in the past. So this work represents the voice of many. And so I just want to make sure that I recognize them as well. So thanks.
Thanks, David, for a wonderful discussion. I think this is such an important area. Example here, but obviously this pertains to what we do in medicine as a whole in all directions. Does anybody have any questions?
Really nice. Here's the challenge when thinking about how we are supposed to do the right thing. A lot of digital economics studies are now being called into question because a lot of the core experiments haven't been used.
Yeah.
And so I'm starting to think that it's not rational actors, but it's rational actors who are simply trying to get through their day.
Right.
So for example, I run a residency program. One of the lessons we teach residents in primary care clinics is we need to triage, right? We've got 20 minutes, right? To static control, the book, static control, the doctors, that substance disorder. And I don't know, and you just can't address everything.
Right.
Just imagine us to get some marketplace
right
to the bottom of the list. So I think that is very promising. It's actually a way to go make it fast.
Yeah.
To people to get write their orders for them. Yeah. Right. That's
Yeah.
really rational.
Yeah. So I appreciate that. I think you're exactly right. It is rational in the sense that, like, you have a life to live, right? And you have 20 minutes. And what is it? There's all this work now of like the 27 things that are required to do at every primary care visit, right? And so like that gives you 30 seconds to do each one of them, and then like in principle have some time for conversation. it's unrealistic, right? And so, and this is why I feel for primary care, because everything's just being heaped on without any kind of relative prioritization about what's important, not important. In that context, this is where I would advocate for us as a specialty group to think about helping primary care in this mission, because we're not only helping them, but we're also helping the population that we care about, or the disease that we care about, right? And so, and it's really about trying to unload their kind of work, but yet still try to maintain autonomy of some sort. And so really, it's really trying to balance, competing priorities for primary care. And I think some of it is rational, some of it's not. I mean, the idea like we want to do the right thing, but you know what? It's hard to do the right thing in very competitive environments, right? Just as you're describing, when you have a lot of things coming at you, you're only going to be able to do one or two of those right things, right? And unfortunately for us, and at least unfortunately for me as a COPD person, it gets, those things get deprioritized, and so nothing ever happens. So yeah.
Brilliant talk. It was a pleasure. The only thing I'm listening to you, you keep saying primary care, and I have to ask, what primary care? We don't have primary care in Connecticut. It's dying away, right? So in some ways, we have to think about systematic replacements, because it's beyond the bubble of the VA. Even in places like Connecticut, it's impossible to get access. And when you get the access, you don't get, as you said, they have 27 things to do.
Right.
And they need to just get you through the door, in and out.
Yeah.
So so are there ways that you could actually maybe start thinking of decentralizing it completely, so not being dependent on it?
Yeah, I mean, I think I'll use lung cancer screening as that model, right? Which I think is probably an opportunity for us to decentralize. I think this is an example of decentralization. The challenge here is that we have no direct relationship with these patients, and so we're just like, like the voice, this odd voice overseer, like making these recommendations, and so there's no trust relationship in that context. Lung cancer screening is something else, right? I mean, like, I don't know how many things that primary care is responsible for the screening process, but they can't get through it all. I mean, and so I think this is an opportunity as for you to leverage data to identify active smokers or people who may be eligible, and then engage them in shared decision-making. Because my sense is that we're going to do probably a much better job with that shared decision-making process around whether or not lung cancer screening is appropriate for them or not than a primary care provider who really probably doesn't actually have all the nuance, around, are they eligible for lung cancer screening? Do they have an adequate number of PAC years? Have they stopped, within X number of years? So, and then, and technically one of the criteria for lung cancer screening is that you can tolerate a lobectomy, right? And how are they going to know that, right? So there's a lot of things that we should be taking off their list, and we should just be doing it in a centralized way. I actually think if we do that, by the way, in the VA, and I've had this discussion with Dr. D'Anatolis, which is that if we do this in a systematic way, we can figure out which ones should be peeled off from primary care, and we should just hand them off to a separate group that we can stand up and silo. And then we can run them efficiently. We just scan the records, and then every patient would have some contact with the system at all times, so that we can do these 27 things throughout the year, as opposed to at the single primary care visit. But there's primary care providers at the same time have an identity, like they do a lot of preventative care. And so what are you going to pull away and that kind of stuff? So there's discussion that can happen and should happen. But I think there are ways that we have to rethink about how we're actually delivering services, because we can't do it the way we're doing it now.
Yeah. One last question from Dr. Soller, and then we'll close up.
Yeah, so let's ignore insurance for a second, right? Because the question is, for them, it's really around benefits and benefits management. Like, insurance is really not about healthcare delivery. It's like, what is your benefit and what do we cover in your premium? there are real issues for healthcare systems, right? So if, for example, you're doing a bunch of inappropriate CT scans, right, for lung cancer screening, and suddenly you take away 20% of them, if there's not a queue waiting for that CT scan, you're going to actually lose revenue as a health system, right? That has to be an opportunity to incent, right? So if you think about, like, CMMI has been criticized because their programs have led to savings at certain levels, but once you include the incentive structure, it hasn't saved any money, right? But I would argue that what you're doing is you're actually like getting the system to be more efficient and to perform better, and you're paying that incent. At some point in time, you could remove that cent, but the structure's there to keep that quality of the cent, keep that quality there, or the processes are there. So you're building processes within health systems to change them. You want to encourage that through whatever financial incentive, so they actually don't go broke. I mean, right now, many health systems are talking about reducing services because they don't generate sufficient amount of revenue. And if you don't generate revenue, you're gonna have to cut back somewhere. And the things they're going to cut back are the things that actually don't generate revenue, and probably incent overuse of things that do generate revenue. And so I think there really does need to be this kind of balanced discussion around, like, how do you keep health systems solvent and healthy so that they can continue to grow, so they can actually serve a public mission, and maintain that in a way that doesn't disincent the low reimbursement models like pulmonary rehab. I think pulmonary rehab is a great example. It doesn't pay very much, but it's a really important program, right? And so, but I guarantee you, like, if it came to pulmonary rehab versus not doing diagnostic imaging, PR is on the chopping block. So yeah.
Thank you so much. That was a really great, engaging, thoughtful, thought-provoking discussion. And I think we'll have to stop now. But if anybody else has additional questions, I'm sure Dr. O would be willing to take them up front. And thank you all for your, and tomorrow research conference is noontime, correct?
Yes.
Thank you so much, David.